Thanks, Mike. So I'm going to be talking about managing leg discrepancy in total barthoplasty. The drapes are off, the leg is long, and now what do you do? These are my disclosures. They're not relevant. Now, leg length inequality remains one of the most vexing problems in total barthoplasty. It's a little bit hard to define. Is it less than a millimeter, 5, or 10? Or is it really based on how your patient feels and their perception of leg length? An estimated third of the patients that we do have a perceived leg length discrepancy post-op. Sometimes it's shortening less than 10, sometimes it's lengthening more than 6, but unfortunately this leads to dissatisfaction, and we know that this is one of the most common reasons for litigation after you do your total hip. Now, today's routine primary total hip essentially should be perfect. Charlie once said that patients very soon become adjusted to a centimeter of over lengthening. This just isn't true anymore, unfortunately. A pain-free total hip just is not good enough anymore, and a happy patient really means no pain, good function, well-fixed implants, a stable hip, and equal leg lengths. Now, it all starts in the office. Do your legs feel equal? Past medical history should include things like spinal deformity or fusion, prior trauma like long bone fractures that you can see on the top right, neuromuscular disease and dysplasia. On exam, you can feel for pelvic obliquity, assess for flexion contracture of the hip, and measure your true versus apparent leg lengths if you can, or if you're concerned. Now, you also have to identify the at-risk patient. This is sort of the prototypical one. This is a short varus neck patient with pelvic obliquity causing lengthening on the operative side. Oftentimes it's female more than male. This woman is a 76-year-old, very anxious woman with a degenerative scoli, pelvic obliquity. The right side is shortened actually because of a prior hip revision, and she's insisting on a minimally invasive surgery the same day, and she demands to be equal. And this is one you just have to promise that she won't be that way. Consider the other side. Encourage your patients, if they have opposite side pathology, to do it in a relatively soon fashion so they're not miserable. This is a 44-year-old gentleman with bilateral hip Perthes disease. We did these 6 weeks apart in a staged fashion so he could have equivalent leg lengths in just a short period of time where they're unequal. Now, I think templating is the key to success in total barthoplasty. The goal here is to restore the hip center of rotation, recreate offset, and correct discrepancies. Here we can determine the neck cut level. I think the acetabular position is the underrepresented thing about leg lengths that we'd never really think about. Stem size and offset certainly can affect things, and a failure to plan is a plan to fail. Now, from a posterior approach, how do you do this? You can just feel for the knees and heels like we do old school. It's subjective. It depends on the patient's leg shape. If they have sort of this triangular shaped leg, it can be difficult. Feel the legs before you make your neck cut, and then compare to what you measured in the template, and then compare with your trials. The Shuck test is pretty unreliable, highly dependent on relaxation, anesthesia, and the soft tissue qualities. You can measure this lesser to center measurement, which is tried and true. Use a bent Steinman pin and bend it 2 times. Use a ruler. There's a number of commercially available calipers and tools which are helpful but not amazing, in my opinion. I use a direct anterior approach for most of my hips. A transitional teardrop blend can be helpful, but you have to worry about parallax of the fluoro and fluoroscopy error inherent in that individual machine. I've gone to more of an overlay technique, which is sort of old school, but I learned from Joel Mata and it has worked well in my hands. Off the table, you can assess the heels and the medium malleoli very easily, or you can use advanced technology. You can use a robot. You can use mini navigation or intraoperative imaging to help you figure out the problems and fix what you got. Now, what happens when it actually does happen? And it's going to happen. Don't panic. If this has never happened to you, you're just not doing enough surgery, because it will happen. Most limb length inequalities of less than 5 millimeters are pretty well tolerated, and it can take 3 to 6 months to improve. And in this time, you should not use a shoe lift if possible for at least 6 months. You want to talk to the physical therapist that maybe wants to use it, and you have to hold their hand a lot. And this is the patient that I'll see more often, or I'll call on the phone when I'm heading home from work. Consider, unfortunately, a same-day revision if you're greater than a centimeter and you're worried about this, though. In conclusion, identify that at-risk patient, counsel them pre-op. It saves you a lot of headache. Pre-op templating is critical. Intraoperatively, develop a reproducible system for you that you can do every single time in a very timely and reproducible fashion. That can be tools, that can be imaging, that could be advanced technology. Lastly, most discrepancies under 5 millimeters will resolve with patience. Thanks very much.